Hello, everyone. Good morning, good afternoon, and good evening. Welcome to this special webinar conducted by Asian Society of Pediatric Anesthesia Cardiac Special Interest Group. Today's topic is navigating anesthesia challenges in the catheter laboratories. Pediatric cardiac catheterization and angiography are two of the methods used in the diagnosis and treatment of patients with congenital heart disease. Anesthesia approaches in these patients are special and come with many anesthetic challenges. The objective of this webinar is to evaluate anesthesia experiences and complications in the catheter laboratory, and we have very special, unique speakers from different countries who will share their experiences with us. And first of all, I want to introduce myself. I'm Dr. Dilek Altun from Acıbadem University, Istanbul, Turkey. My interests are pediatric anesthesia, adult and pediatric cardiac anesthesia and intensive care unit, pain management, difficult airway management, difficult vascular access. And today I will be moderating this webinar with Tao Jiang, who is pediatric cardiac anesthesiologist from Vietnam. Her interests are pediatric cardiac anesthesia, lung ultrasound, and protective lung strategy in minimally invasive cardiac surgery.
Thank you, Professor Dilek. I will talk about some rules of our webinar today. I'm very happy to be here. We will save all the Q&A at the Q&A session. In the webinar platform, you cannot use the chat and raise hand function. And we, the moderator, will highlight your question to the appropriate speaker during the panel discussion. And some questions will be answered by the appropriate speaker in the Q&A form. So please check it. And before each session, we are also doing a poll. When the poll is launched, it will be prompted to answer the poll question within 30 seconds. And we will set the result soon after we end the poll. And remember that the poll in this webinar, in this special webinar, is not right or wrong. It's for the aim of surveys. And after the result is set, you can close the poll so that you can see the slides there by our speakers. And also after the webinar, we provide the certificate of attendance. Please scan the QR code at the end of the session to access the MCQ and survey form. And our certificate of attendance will be forwarded if you successfully submit the MCQ and survey. And so please ensure that you have correctly keyed in your full name and your email address. We are available in 3 platforms at the website aspire2000.com, at Facebook, and all the video will post in the YouTube. So please visit and like and follow us. This is a special disclaimer because the view and opinion expressed by the speaker during this webinar are based on their individual practice and experience. The content discussed is intended solely for education and discussion and should not be interpreted as a universal guideline or official recommendation. So attendees, please, you are encouraged to critically evaluate the information presented here and apply it in the accordance to your own professional judgment and institutional policy. So now we will come to the first topic with a general consideration in the Cath Lab. The point here, please prepare. In your institution, who provide care for patients in the Cath Lab? 1, pediatric cardiac anesthesiologist. 2, any pediatric anesthesiologist. 3, a select group of pediatric anesthesiologists. Or 4, adult cardiac anesthesiologist. You have 30 seconds. And the point number 2, what is your most common approach for post-procedure care for the pediatric patient in the Cath Lab? For example, after the device closure. 1, admission to the ICU for monitoring. 2, admission to the high dependent units for monitoring. And 3, admission to the general ward for monitoring. And 4, discharge home within a few hours if the patient is stable. Wow, this is the result from our poll. It's showing that the varieties of approach. So now we will come to the session with the first speaker.
Yes, now we will see the answers of these questions in the speech of Mr. Rafik. I want to introduce Mr. Rafik as the first speaker. Mohammed Babar Rafik, he's from USA. He's the professor of anesthesiology and is working in Strict School of Medicine in Loyola University, Mammoth in USA. His interests are pediatric anesthesia, pediatric cardiac anesthesia, pediatric airway management, and ultrasound-guided regional anesthesia. Please, Rafik, the floor is yours.
Hi, good morning, everybody. As you know, I will be talking about general considerations in the pediatric catheterization lab. As everybody is aware that pediatric catheterization lab is a very complex environment. You are in a place where you are away from the operating room. There are several moving parts which are related with the X-ray equipment, and then somewhere in the corner you will have your own anesthesia equipment, and the people who are helping you are around you. If you're not there every day, you may not be familiar with their names or their ability to help, or they may not be aware and able to help you with any anesthesia situations which you may have during the procedure. So knowing the place, knowing the team, knowing everybody there is very important. And still, you have to have your own stuff ready, because anything you need extra may not be immediately available. Somebody would have to go to the wherever anesthesia equipment is stored, which could be far away from the from the cath lab, and it may take time and people to bring it. In general, as I said, it is a complex environment. There are several hazards, including ambient temperature, radiation exposure to you, lack of proximity to the patient, and age of the patient, which is a big variety in pediatrics. It could be a neonate, it could be a 10, 12 years old patient. And both of those patients have different needs and different issues which you may have to address. I'll take them one by one. Temperature control. The smaller children, especially neonates and children less than 2 years old, are at a very high risk of getting um, very cold. And you have to think, oh, what is the environment. Usually, when almost all the cath labs are maintained at a temperature of 67 degrees Fahrenheit. And in the operating room, when we get a small child, we usually crank the temperature up and bring it to our desired temperature, which is usually 78 degrees Fahrenheit or more. But that is usually not possible in the cath lab, because if you do that, the humidity in the air changes, and that could affect the catheterization X-ray equipment, lab equipment, and that may not function if the temperature humidity is higher, because of the moving parts in the X-ray machine. So you have to adapt to other strategies to be able to keep your patient warm. The most common and most effective uh, piece of equipment is your bear hugger, or warm air blowing equipment. Most of the times we use underbody bear hugger, and we put it on before the patient is sent for, and we do not increase the temperature in the room, but only uh, underbody bear hugger, and we turn on the bear hugger to highest temperature until the patient arrives. Once the patient arrives, we bring it down to 1 notch below the highest temperature, which is 43 in our machine setting. Different machine settings could have different settings. If we are getting a neonate or a premature neonate, we usually add the warming lights, and they are available in the catheterization lab for us, and we turn it on before the baby is sent for. Usually it takes about 15 to 20 minutes for the baby to arrive, and usually the light warms the area quite well. And last but not least, we usually use on almost all our patients, especially if they are smaller in size, heat humidity exchanger. There's a lot of those different sizes available in the market. The ones we use is only 2 cc's dead space. That is very important. If you use a device which has a bigger dead space, there could be problems, especially ventilation problems, and you could be retaining CO2, and it may not be possible to ventilate the CO2 out until you exchange that device. Either take the device off or put a device which has very small dead space, because you have to keep in mind that most of these children, especially the premature babies, are only a few hundred grams or maybe uh, a kilogram, and in that case it will be really difficult to ventilate them with anything which has bigger dead space. So these are the three things which usually are very effective to keep them warm and avoid any drop in temperature. But you have to plan, you have to start early. The next thing is anesthesia equipment, which is again, as I said earlier, that usually you have anesthesia machine in there and it'll be somewhere in the corner. But some of these babies, especially the premature neonates, when they come to the catheterization lab, the anesthesia ventilators may not have all the modalities which you can use to ventilate them effectively. But some of those NICU or PICU ventilators are very effective in ventilating them. So you have to think ahead and have that conversation with the intensivist or neonatologist, that how was their ventilation in the unit, and will you need a NICU or PICU ventilator, which has a lot more modalities to ventilate the baby. And if that discussion has happened and you have the ventilator available at your disposal, if your anesthesia ventilator seems to be ineffective, you can quickly switch to the NICU or PICU ventilator. The only challenge with that will be that once you switch to that, you will be dependent on TIVA only, and you will not have your anesthesia gases in the system. But obviously, you have to plan ahead, and you have to have alternate strategy available in case you are going to go to PICU ventilator. Um, Next is intubation. For anyone, a child with especially neonates and a child with any dysmorphic features, intubation could be a challenge. And if that is something which you anticipate or you have suspicion that could be the case, you have to have your video laryngoscope available in the catheterization lab before the baby arrives, because if there is any challenges, and you may be you may be Allahu Akbar, Allah. You may be in difficulty, and you may have to wait for longer. So to have the video laryngoscope available in the catheterization lab is very important in case you are anticipating any difficulty with the intubation. Radiolucent EKG leads. These are usually available in the cath lab, and you have to remember that even if the baby comes with EKGs and other monitors on, you have to remove those EKGs, and you have to use the radiolucent EKGs in the catheterization lab. If you forget that, then you may have to do it under the drapes during the procedure, which is not a easy experience. And if you are anticipating that you may be transfusing to the patient, you have to have some kind of warming device available at your disposal in the catheterization lab so that you can warm the blood, or even if you want to warm other IV fluids you are giving, that will also help with your temperature maintenance. How to draw drugs, and that is something you have to keep in mind, that if as a general rule, if your length of the syringe seems to be equal to the size of the baby or length of the baby, that may not be the best thing to do. You have to have your anesthesia drugs drawn um, ahead, and also you have to have emergency drugs available ahead of time. I usually draw things in this way. The anesthesia drugs we usually draw in 1 cc syringe, one propofol for 1 cc syringe, rocuronium for 1 cc syringe, and usually dilute the fentanyl to 1 mic per cc dilution. So in a 10 cc syringe, 10 mics added diluted to 10 cc's. Also, we always have epinephrine drawn in 1 mic per cc and 10 mic per cc concentrations, and obviously calcium chloride in a 1 cc syringe. 1 cc syringe just give you ability to give the medicines very precisely, whatever amount you want to give. And diluted fentanyl, 1 cc of fentanyl is easy to give, and it is, if you want to give 1 cc, you know that it will get in. If you use undiluted concentrations of fentanyl, it may be hard to give very small doses of fentanyl in that case. So drying the drug ahead of time and drying them in a very precise manner is very important. 1 cc syringes for any child who is uh, less than 6-7 kilos is the best strategies. Only the propofol you can draw in some slightly bigger syringes like 3 cc if the baby is about 7-8 kilos, but other meds you have to draw in very small quantities. IV access and monitoring. IV access, as you know, is very important. In our institution, a lot of children come from home as outpatients, so they come without an IV access. And even when they come to the catheterization lab from the floors, if they have an IV on the lower extremities, that may not be the most appropriate thing for the catheterization lab medicine administration, because once the baby is asleep and the cardiologists start working, they're going to get access at the femoral. That is kind of standard. And access is, if it is challenging, they're going to use both femoral veins for that. They may be poking for a while. And if those femoral veins are accessed, then your meds are not going to get to the baby, and probably if your access is in the lower extremity. So getting PIV in the upper extremity is very important. Also, if a patient comes with a PIC line or a central line, that may be good for starting the case, induction of the patient, but that is not appropriate in case you get into trouble and you have to transfuse or you have to give bigger volumes of fluids quickly. So even if the baby has a PIC line or a central line, you may have to have a peripheral IV in the upper extremities as a way for you to give volume to the baby. So upper extremity IV, and if there is a central line, still you have to put an IV. Usually what we do is when the baby comes in the cath lab, at the time of induction, put the pulse oximeter and blood pressure cuff on both lower extremities, so that we have upper extremities for placing IV. Once the IV is done and everything is secured, we switch the pulse oximeter and blood pressure to the upper extremities, because they are going to be working on the lower extremities, and your pulse oximeter may not be most accurate when they are messing with that femoral artery. And same is true for the blood pressure cuff. If they access the femoral artery, then your blood pressure is not going to be accurate from the femoral, from the lower extremity blood pressure cuff. As I said, pulse oximetry site, we prefer it on the upper extremity, usually the same hand where you have your PIV placed. And same is true for the blood pressure cuff. Also, a lot of cath labs use additional monitoring, like regional tissue oximetry, called the most oldest system is INVOS. Some places use both a cerebral probe as well as a tissue probe in the somewhere in the back of the patient, uh, also called in the kidney area. They have their advantages and disadvantages, but if your institution uses it, you have to make sure that if it is a very small preemie, the back probe may be pushing too much on their tissue and could cause burn. I have seen burns with that. So if you put them on, you have to keep an eye on it. And the other thing, a lot of people talk about if they are going to be doing any uh, general versus sedation. In US and in general in our practice, we almost always do GA. And the reason is if they're doing diagnostics, they will be asking for Roumier's condition. And if you're giving sedation, baby may need some additional oxygen with nasal cannula or face mask to remain oxygenated, and that is only going to make things complex. So doing a GA is the most easy and efficient way to do it. Also, if they're doing any interventions, you don't want those babies to be moving when they have their balloon somewhere at a critical point where it took them a long time to get. And if you have only sedation, there is always a risk of baby moving. So general anesthesia for pediatric catheterization labs is the best strategy. Um, the last thing which I want to emphasize is, one, babies are very small, so you have to keep an eye. These cardiologists are very good. They are very dedicated to their job. Once they start working, they forget that it is a small baby. They may put their hand on the baby's belly or chest and push it so much that you may not be able to ventilate. So you have to keep that in mind. You have to keep reminding them. And because you are far away from the patient, you have to have your IV made in a way that you can give meds from a distance and effectively reach the baby with minimal amount of flushing the drug to the patient. Um, Type and cross. As a general rule, if they're going to do any intervention, you have to have a blood available in the catheterization lab. That is our practice. We never let anybody balloon or change or place a valve without blood at hand, because you never know when things could go wrong. So you have to keep that in mind. This is just a review of everything we talked about: temperature control, anesthesia equipment, how to draw drugs, IV access and monitoring, diagnostic versus interventional, size of the patient, and type and cross for the blood. Thank you very much.
Thank you, Professor Brafik, for your presentation. And now we will move to the next session about the sedation in the Cath Lab. And we will have the poll. Remember again that the poll is not for the right or the wrong answer, but it's for the survey purpose. So poll number one, in your practice, what is the most common approach for 1 year old for PDA device closer? Number one, sedation with the natural airway, whether it is oral or nasal airway. Number two, general anesthesia with spontaneous breathing or with some extended pressure support. Number three, general anesthesia with positive pressure ventilation. Number four, you unsure or no experience. Or number five, none of the above. You have 30 seconds for each poll. Wow, here is the result. 50%, the highest number, with using general anesthesia with positive pressure ventilation.
Thank you again to Dr. Rafiq for his comprehensive speech. Now, I want to introduce our second speaker, Dr. Luisa Jongo from Philippines. She is the consultant in pediatric interventional cardiology. She's working in Philippine General Hospital, the Los Santos Medical Center, and Chinese General Hospital and Medical Center. Her interests are congenital heart disease in children, congenital heart echocardiography, fetal echocardiography, cardiac catheterization, transthoracic echocardiography, and critical care for pediatric cardiac patients. Now it's your turn, Dr. Lisa. We are listening to you.
Good day. I would like to thank ASPA for the invitation to speak today. I am Dr. Luisa Joango, pediatric interventional cardiologist, who will talk to you about considerations for sedation for children in the Cath Lab. I have no financial disclosures related to the topic. The objectives today are to discuss the common cardiac cases in our institution, present our present practice for sedation, and discuss the considerations for sedation for children with congenital heart disease, as well as some complications that we watch out for after the procedure. So I presently work in one of the hospitals in the Philippines, and our cardiac cath demographics are as follows. So we have mostly simple lesions, such as PDA, which comprise 80% of our census, VSD device closures, which is 5%, atrial septal defect about 1%, and pulmonic stenosis, which is about 8.6% of our patients. We also have 1 or 2 aortic stenosis cases. We only have about 1.6% complex lesions, such as pulmonary atresia, tricuspid atresia, TOF, TGA, or TAPVR. So these kids typically get BAS, balloon atrial septostomy, BAS, or PDA stenting if needed, or RVOT stenting. So at present, most of the simple lesions, we do not refer to anesthesia. So all the PDAs, we just sedate on our own, the VSDs also, but all the ASDs that need intubation, we refer to anesthesia. And all the complex lesion which require carotid access needs to be intubated and referred to anesthesia for sedation. So some of the salient points of the procedure is that we typically have our patients supine. We have to give sedation for older children to keep them calm. We don't really need to control ventilation for most part because we want them spontaneously breathing. So we also just need to have them relaxed enough so we can position their legs and their arms raised. We also give local anesthesia to our puncture site so that we don't need to really knock them out. And typically we use the femoral vein and artery for most of our access. And then after we access that vessel, we eventually upsize the sheath to allow us to deliver whatever device we need. And then after that, we do remove our catheters and do hemostasis. So this is basically how most of our simple procedures go. So I will show you what PDA device actually looks like. So this is an angiogram showing the 2 catheters, so one from the aortic end and one from the venous end, and that the PDA is in the center. So in this next video, the device is already being put into the PDA. And then the third video will show us that the lesion is already almost completely occluded. There is still expected residual shunt after the procedure because it's not a solid metal that you put in. So for our practice in our institution, it's very different from, I think, most of the other countries because we have limited access in terms of staff for anesthesia service. So the simple cases, usually we just need to sedate them just until the end of the procedure, until we make the hemostasis. Usually, typically from 30 minutes, at most 45 minutes. And then we just need to make the child comfortable and less anxious. And we also need to consider that we have to have medications with less hemodynamic compromise because these are actually cardiac cases. and we need to be able to monitor the status of our patients. So what we do in our institution is typically do a combination of meds. So we give midazolam, ketamine, and nalbuphine as a cocktail, usually for most of our patients. And we pre-medicate them with diphenhydramine and some steroids prior to giving to the table, especially if there's a risk of having allergic reaction to contrast. I think Dr. Gumintad will be discussing more on the medications that can be used, but this is our present meds for our own patients. And if we know that the patient has severe pulmonary hypertension, we tend to use a little bit less ketamine for them. So how do we choose what type of anesthesia to give? How do we choose if we need to call in and wait for our anesthesia service to be there to do the procedure, or can we do it ourselves? So first and foremost, of course, is the age and the weight of the patient. So if you have a bigger child, they may be cooperative enough to not need much sedation. So we typically do the big kids awake or just a little bit of anesthesia. And then the smaller children, we need to give them sedation because we cannot really tell them to not move. So the neonates and the premature infants are more vulnerable for apnea and hypothermia. So these are typically the patients that we need to refer to anesthesia service for co-management during procedures, especially if their procedures are more complicated. And ironically, the complex cases are typically those in the neonates because of the mere fact that we need to do something in the neonatal period means that it is a critical congenital heart disease. So most of the time, the neonates we do refer. But the simple cath procedures, especially if it's just a short procedure, we can just do our own sedation. So especially if it's just a PDA, 15 to 30 minutes at most. Yeah, so we just do that. And if we don't really need to manipulate as much, we can actually do just sedation. If we also expect to use the carotid or the IJ, typically we need to refer to anesthesia because we need to protect the airway and we need to protect the head when we're moving it. And especially if we need to do TEE, so we usually refer to anesthesia for co-management for these patients because they need to be intubated for the procedure. Or if we do procedures that requires transeptal puncture, that also needs TEE. And also we need a patient who's not gonna move when we're trying to puncture or create a hole in the heart. So those are the typical patients that we need GA for. But if it's just a femoral approach, we don't really need to knock them out so bad. Also, the other patient characteristics that we consider is if the patient is severely sick, intubated, cannot be ventilated well, those with bad comorbidities, those who are desaturated or in shock. So those are the patients that need to be critically monitored. So that needs a full team to really sedate the patient. And also, our institution already has a staff that's very, very well trained in terms of looking out for the problems that the patients will have post-procedure and during the procedure. So the staff readiness is crucial before you really say, we can just sedate on our own. And of course, the operator or the doctor should not be alone. You should have a team. So it's usually in our setting, we are 4 cardiologists who are in the room. Sometimes we still have our residents who are in pediatrics who help us with the cases. So it's not really just the operator doing the sedation alone. And you have to consider that this is a resource-limited setting. We don't have everybody there all the time. So that's the reason why we actually have this own set of sedation protocols for our children. So now we go on to the post-procedure care and monitoring. So immediately post-op, there can be respiratory distress, there can be congestion. Emerging from anesthesia, they can have vomiting and eventually aspirate. So we really need to be able to watch out for these. And sometimes we see allergic reaction, especially if we had to use iodinated contrast. So sometimes it manifests as rashes, abdominal pain, sometimes vomiting, sometimes shock. So anaphylactic shock. So we have to be very careful and monitor these patients for a few hours before we send them back to the ward. So in our case, we send them back to the wards. We don't send them back to the ICU unless they're intubated. And then for the device closure patients, we need to be very careful about watching out for device embolization. So how do we do this? How do we check this in the post-anesthesia care unit? So it's important for all of us to have a baseline physical examination of what the heart sounds like. And then after we close the device, with a device, usually the murmur will go away or change in character. And we have to have a note of what that sounds like so that after the procedure, that should remain the same. If the murmur comes back to the pre-closure state, that means your device probably has embolized. So we need to get a chest x-ray to check, or an echo if it's available. But usually in our institution, we do chest x-ray to check if the device position is still in place after the procedure. So that's also before they go home. So that's a later complication also. So sometimes the device stays there for the first few hours, but when the patient wakes up, strains, cries, if it's a baby, sometimes you can still get late onset device embolization, but that's rare. So it's still important to monitor these kids after the procedure. And then later on, aside from the initial bleeding in the access site, later on, there can still be hematoma formation or vascular complications that develop down the line. So there can be limb thrombosis, arterial thrombosis, limb ischemia. And some patients will develop arteriovenous fistula, but that's very rare, but it has happened. So those are the things that we watch out for later on in the course of the patient. Also, some of the devices will have persistent residual shunting, but that's a very rare complication, but that's something that the cardiologists actually monitor later on. So our own experience is actually very different from most of the advanced world, but we believe that balance is key. So the balance of being able to help your patients to get the procedure done in a timely manner versus the risk of not having anesthesia service on board during your procedure is something that needs to be carefully balanced, because you have to know yourself what you can do, what your institution can do, and how you can protect the welfare of the patients, but not create a very long backlog if you really need to wait for other people to be there for you during the procedure. So it is actually a very efficient system for us because we've been able to do more patients in a shorter time, because we can just sedate them and then let them go. But of course, if it's a very complicated case, if you expect problems, it's very important to have all the services you need on board and ready to help the patient whenever the patient will need it. So thank you very much. If there are any questions later, I will be glad to answer your questions. Thank you.
Thank you, Professor Luciana Rangel. I'm very like your statement that for sedation, the staff readiness is critical. And we have seen more sedation in our webinar, and we will go with the next session and about the providing general anesthesia care in the Cath Lab. We will start with the poll as usual. So the poll is, how do you typically manage neonate undergoing cardiac catheterization? For example, a neonate for a pulmonary balloon valvuloplasty. Number one, use sedation with natural airway. Number two, general anesthesia with spontaneous breathing with some extent of pressure support. Or number three, general anesthesia with positive pressure ventilation. Number four, unsure or you have no experience. Or number five, none of the above. Here, the result for the general anesthesia is account for 72%. Most of the audience will choose DA with the positive pressure ventilations. Now you can close the poll and start with the next session.
I want to thank Dr. Lisa. She talked about sedation in the Cath laboratory from the perspective of a pediatric cardiologist. Now, Dr. Gina Gumented will give a bit about the general anesthesia from anesthesia perspective. Dr. Gina Gumented is a clinical associated professor working in University of the Philippines in the College of Medicine. Her interests are pediatric anesthesia, adult and pediatric cardiac anesthesia, thoracic and cardiovascular anesthesia, critical care medicine, and point of care ultrasound in anesthesia and critical care. Now it's your turn, Dr. Gina. We are listening to you.
A pleasant day, everyone. First, I would like to thank ASPA for this invitation to share with us all this afternoon our anesthesia practice for children in the Cath Lab, in the cardiac Cath Lab. First, I would like to mention that I have no disclosures. The patients presented in this case, as well as the images, are my own patients. So is this place familiar? This is how it goes in our local setting. This is one of my hospitals where I work here in the Philippines. This is how the setup goes in our cardiac catheterization laboratory. So it's a bit challenging if you see like this, especially if we have a challenging patient. So to begin, let me present a case of a 2-month-old baby girl weighing 2.2 kilograms with pulmonary valve atresia with ventricular septal defect and tortuous patent ductus arteriosus, delivered preterm at 33 weeks by cesarean section, referred for PDA stenting via carotid access. Currently, the patient is on room air with running alprostadil infusion. Heart rate is 144, BP is 105/52, respiratory rate at 40s, oxygen saturation at 90% on room air, with significant grade 3/6 systolic murmur and left upper parasternal border. So if we get to have this patient scheduled for elective PDA stenting with carotid access, how do we go about this patient? So first, as what Dr. Go has discussed in her lecture, in our setting here in the Philippines, I work in 2 institutions that do a lot of cardiac cath, congenital cardiac cath. We can divide them into simple lesions and complex lesions. The complex ones comprise approximately around 2%. This includes pulmonary atresia, single ventricle physiology, tricuspid atresia, the tetralogy of Fallot, the TGAs, the total anomalous pulmonary venous return. The simple ones, we can group them. We have the PDAs, simple VSDs, the simple HASDs, those with isolated PS, and those patients with isolated aortic stenosis. So this has been presented by Dr. Rago. And how do we go about this patient? So we get to have that patient, 2-month-old, 2.2 kilogram delivered preterm, a preemie patient on alprostadil, cyanotic. So what we do when we first receive the patient in the holding area, we do our quick history and PE of the patient. We go about with, we focus on cardiovascular function with emphasis on signs and symptoms of left and right cardiac failure. We go about having a baseline oxygen saturation and check on the current medications of the patient. And then very important also is we need to review the transthoracic echocardiography to check for structural and functional heart defects, as well as to check on the estimation of the pulmonary artery pressures. So we have this restratification, we call that risk, or we know this as the catheterization risk scoring for pediatrics, which is very useful if we get to receive patients like this. This can be used to predict the risk of adverse events in higher risk patients. This uses age, weight, inotropic support, if the patient is on inotropic support, systemic illnesses or organ failure, and also the physiological category and procedure category of the patient. We also have this predict scoring, which is our procedural risk in congenital cardiac catheterization. This includes risk categories, grouping cases according to procedures that had the same incidence of the defined high severity adverse events. For our patient, the patient is less than 1 year old. The patient's weight is 2.2 kilograms, which could give you a higher score. Not on inotropic support, but on alprostadil. Systemic illness or organ failure, none yet noted. Physiologic category is 3. This is emergency. And procedure category, this is also considered a category 3 because PDA stenting with carotid access on a neonate is considered a high-risk intervention for this group of patients. So what do we do? That's what we do in the holding area. We do a quick history and PE, focusing on the cardiac physical exam of the patient, and then we get to talk to the parents, explain the procedure and the anesthetic plans, and then we obtain a written consent for anesthesia. For our patients, we give them premedication. We usually give diphenhydramine 1 milligram per kilogram per dose and hydrocortisone 2 milligram per kilogram per dose. We give this usually when they are on their way to the cardiac cath, from holding area to the cardiac cath. And then when they arrive in the cardiac cath, in the cardiac cath suite, this is how we do. We establish if the patient is for IV sedation or the patient is, we need to intubate the patient. So Dr. Luisa Go already discussed the considerations for choice of procedural sedation, from patient characteristics to complexity of the case, even taking into consideration the capacity and competency of the whole Cath Lab staff. So for those simple cath procedures, we just require enough time to finish. So we do it under IV sedation. Complex cases, they require longer time and needs cardiac anesthesiologists to monitor and might need as needed. Given the evolution of procedures visible in the Cath Lab, the decision on who qualifies for sedation or needed to be intubated for the procedure needs to be established. So even beforehand, we get to talk to the guardian of the patients or the parents of the patients. We need to establish with them if we will be doing purely IV sedation or we need from the start to intubate the patient. So our anesthesia could range from sedation to monitored anesthesia care for simple cases or general anesthesia for complex high-risk cases. So some of our simple cases, we have those simple, shorter procedures, those bigger kids, which can be done with femoral access, low-risk patients like your simple ASDs, simple VSDs, and if the staff is also competent in handling, sometimes anesthesiologist is not available, cardiac anesthesiologist is not available. So it's the nurses who assist the cardiologist or the interventional cardiologist in sedating the patients. And also, of course, availability of resources. On the other hand, if we consider to intubate the patients, these are the more complex and longer procedures, especially the neonates, preterms with carotid or sometimes axillary access, high-risk patients, which includes those with hypertrophic cardiomyopathy, single ventricle physiology, aortic valve stenosis, mitral valve stenosis, pulmonary hypertension, pulmonary vein dilation, or those who have left AV valve hypoplasia or post-heart transplant patients. And sometimes we also need to consider intubation if the patient is a smaller kid and we need to do TEE. The manipulation of the TEE could be disturbing and can lead to other complications. So sedation has more cardiovascular stability. Maintenance of, you can maintain spontaneous respiration and you can have a calmer emergence, more calm emergence. However, it carries the risk of airway obstruction sometimes when you have already deepened the anesthesia and the patient starts to develop already had CO2 retention. So there can be hypoventilation and could result to a higher pulmonary vascular resistance and a risk of patient immobility. So sometimes the patient also tend to cough and move during contrast injection if the patient is only sedated, and this could have deleterious effects on the outcomes. With general anesthesia, on the other hand, there is better immobility, minimal response to painful stimuli, and psychologically better tolerance for future interventions. Induction plan is determined, of course, by the patient's physiology. So what is challenging if we receive patients like this in the OR? First is challenging if they have no intravenous access. Sometimes they have no intravenous access. So we usually administer intramuscular midazolam at 0.2 milligram per kilogram plus ketamine 2 milligram per kilogram plus atropine 0.01 to 0.015 milligram per kilogram to facilitate IV access. And then once the IV access is already established, that's when the time that we give the rest of our anesthetic medications. So invasive lines are required for these procedures. Invasive lines are required pre-induction if higher risk. but they are inserted by the interventional cardiologist during the start of the procedure. So disadvantages of general anesthesia can also be venovasodilation. Your cardiac output can be compromised also if the anesthesia was really deepened and have already given much of anesthetics. Myocardial depression, as these medications alter angiographic measurements and shunt fractions. Sometimes if the anesthetic is already very deepened, sometimes the measurements become less. Positive pressure ventilation can cause also low venous return, low flow across valves, lowering metabolic rate and oxygen consumption, which can worsen the accuracy of the measurement. So we need to really balance if we'll do IV sedation or we need to really intubate the patient. Of course, the benefit would be much over the risk for this type of anesthesia goals for our patient. So how do we go about next? So what do we do? So going back to our patient, this is a case of, this is a 2-month-old, only weighing 2.2 kilogram, single ventricular physiology, has a shunt, has a PDA, but not oxygenating well, or only 90% on room air. So there's a need to do the PDA stenting to establish a more or a better pulmonary circulation of the patient. But it will be done as via carotid access, which will be done by a cardiac surgeon. So our plan for this patient is to do this under general anesthesia. So the patient needs to be intubated. So how do we go about intubating this patient? What do we give, and how do we go about with giving the anesthetics for this patient? So this is how we do this in our setting. This is also in one of the hospitals I work here in the Philippines. This is our setup when we receive a patient like this. So very important monitoring intra-op. We have, of course, we established that we have already prepared our as a standard monitors. ECG, we use 5-lead ECG, pulse oximetry. We have non-invasive blood pressure monitoring. We have all those. And then, of course, the Cath Lab itself presents unique challenges. Preparation, first, we need to prepare meticulously at the aired IV extension tubing, and the vasoactive medication infusion should also be considered. So we have a standby infusion pump or standby syringe pump in case you might be needing any vasoactive medication. So actually, we have a limited space in the Cath Lab. It's a sizable suite footprint. So access to the patient sometimes remains limited by equipment and other specialists centered around a very small patient, as we can see in this picture. So the patient is very small, covered by the drape, and we have a very limited space because also of the C-arm of the image for the imaging of the patient. So very crucial also is patient positioning. We need to meticulously position our patient and set up the patient to ensure that adequate monitoring is in place. So establish secure IV access. Equipment is oriented in a way that it will not disrupt the procedure. So you need to really check on where the equipments are placed that cannot disrupt the full conduct of the procedure. So sometimes we place the hands of the patient above the forehead, but we need to be very careful in positioning patients like this to really check that there will be no brachial plexus injury. So we also put a wedge under the hip of the patient, but this is very helpful for our interventional cardiologists to access fast access for femoral access, but this can affect ventilation. So we also need to check on the ventilation from time to time. If we have capnography, it would be best to really monitor ventilation of our patients. We have to be vigilant all throughout and watch out also for bleeding. So we have to really look also on the field at the same time, watching over our patient and caring over our patient all at the same time. And also another that we need to monitor is anticoagulation. This may be necessary, and this can be this depends on the proposed intervention and the anatomical considerations of the child. Typically, we give heparin 50 to 100 units per kilogram once vascular access is established, and we monitor ACT every 30 minutes or sometimes every hour to check on it. So analgesia is also very important. Requirements for analgesia is variable, generally consists of a combination of local or regional anesthesia. In our setting, we infiltrate local lidocaine with bupivacaine, or sometimes just pure lidocaine, computed on the patient's toxic dose. I usually give paracetamol for post-op analgesia, and sometimes could be supplemented by nalbuphine as needed if the patient is really in pain. We can tell by vigorous crying or irritability immediately post-op. Sometimes also opioid can be required, and just a little loading dose prior to the finishing the procedure. So also another thing that also we need to consider in the Cath Lab handling these cardiac patients is radiation safety. As you can see here in the picture, the anesthesiologist, this is me. We are very close to the radiation, so we really need to suit ourselves the best way that we can to protect us. We should have a lead apron, thyroid shield, leaded glass, a screen, and appropriate eyewear for these procedures because we are so near the radiation. So general radiation safety best practices should be practiced by us to minimize. So we minimize exposure time, maximize the distance from radiation source, and we use appropriate radiation protection. So if we don't have, we're not handling the patient really, or we're not doing manual bag ventilation, so we can go farther, like 6 feet far from the radiation. And we should wear a dosimeter and minimize patient exposure wherever is possible. So this is how it looks like in our setting. The anesthesiologist is very near the radiation. This is a very small patient surrounded by many interventional cardiologists. So this is the PDA stenting patient. This is what we are doing. So this is how we maintain the anesthesia. We can give boluses of medication. So what medications should we give intraop? So intraoperatively, we start with opioids. Our option is we can give fentanyl. Timing of the dose, timing and dosing is very important for these patients. They are very small. We cannot give them all the medication at once. So timing is very crucial and very important. The moment that the patient is already laid down on the Cath Lab bed, that's when we give it titrated amounts of our medications. So we can give fentanyl. This is a synthetic opioid agonist, which acts primarily as the mu opioid receptor. So fentanyl signals downstream. It leads to inhibitory effects, leading to decreased cyclic AMP production, decreased calcium influx, leading to CNS increase in pain threshold by changing the perception of pain. So that's what fentanyl does. So we give fentanyl usually, I start with 0.5 mics per kilogram, and then I can add another 0.5, depends on how long the procedure takes place. And then another medication that we use is midazolam. Midazolam is a short-acting benzodiazepine. So it induces sleep, it gives sedation, it reduces anxiety of the patient, and it gives anterograde amnesia, and also as well as muscle relaxation and anticonvulsant effects. So we give this at a dose of 0.05 to 0.2 milligram per kilogram, also titrated. I give very titrated doses when I give my medications, and I usually really time it, not to give it all at once, all at the same time. And then we also use ketamine. Ketamine is an NMDA receptor antagonist, which results in analgesia by preventing central sensitization in the dorsal horn neurons. So in other words, ketamine's action interfere with pain transmission in the spinal cord. So it is an adjunct to your opioid and also to your midazolam. So propofol, I also use propofol in a very, very titrated doses, because as we all know, propofol is a myocardial depressant. So very titrated doses at 0.5 to 1 milligram per kilogram per dose. I just bolus it. I give it as a bolus as needed. And volatile anesthetics can also be used if the patient is intubated, like this patient. I also use a low dose or low percent concentration of sevoflurane, sometimes at 0.6 to 1 or 0.5 MAC. 0.5 MAC of sevoflurane. So actually we have a lot of choices on what to give these patients, but our main goal is to immobilize the patient at the same time maintaining adequate hemodynamic stability of the patient. So these are the medications that we usually give our patients. These are the what we need to balance is what is very important to balance in these patients is the balance between the pulmonary vascular resistance and the systemic vascular resistance. So these are the following effects of our medications that I mentioned. How if we want to maintain balance between SVR and our PVR, these are the dosing that are acceptable of these medications. And lastly, after the procedure, if the procedure concludes, how do we go about during the recovery of the patient? So the main independent risk predictors of complications are age, less than 1 year old, those with hypoplastic left heart syndrome, and these patients. Studies have also shown that interventional procedures have a higher risk of complications than diagnostic procedures. Of course, it's understandable because there is more manipulation of the heart, of the blood vessels, compared to just doing a diagnostic procedure. So we already have advancement of cardiac catheterization laboratory at present, and they have greatly improved our quality of care. It enables us for early intervention and consequently prolong the quality of lifespan for these pediatric congenital patients, those with congenital heart disease. They have also increased the number and severity of potential complications, very, very much decreased because of this procedure. So what do we do after the procedure? If I intubate the patient, I use rocuronium and I reverse rocuronium with Sugammadex, and also after proper suctioning and checking all reflexes are intact with the patient, I extubate. And then, of course, once they're in the recovery room, still be adamant with putting in our monitors. Resuscitation medications and equipment are also equally important, especially in the recovery room. You need to watch out for bleeding from the vascular access sites and also agitation. Agitation can be a sign of hypoxia also, or acidosis. Complications, watch out for these complications. We can have anesthetic complications, procedure-related complications, environmental complications. So for the anesthetic, these are the things that we need to watch out for. Hypoxia, loss of cardiac output, when the patient has developing hypotension, tachycardia, immediately post-op. So we really need also to be very keen with these events. Procedure-related arrhythmias, pulmonary hypertensive crisis, air embolism, all of this, or sometimes it also happens in our institution, a stuck guide wire or device failure and embolization. And environmental complication as hypothermia. So we have to make sure that the patient is thermoregulated even inside the cardiac cath lab, which is equally important with all the rest of our hemodynamic monitors is thermoregulation. So that being said, nowadays it is we have already a very advanced cardiac catheterization laboratory, and sometimes the patients are very challenging to start with, but if we give our utmost of care and we think of patient safety, well, we can be really giving back our patients what is due them, the care and that we can give to them. So with this, thank you very much for your kind attention. A pleasant day, everyone. First,
Thank you. Thank you, Dr. Sheena. It's very informative presentation about the Cath Lab, and I love your clearly interpretation of your strategy for a specific case and about the technique and especially about the medication. And now we will come to the Fontan patient in the Cath Lab, and with the new drug, maybe not much familiar with the majority of the audience is the drug remimazolam, please. Now, we will have the poll. Are you familiar with the use of remimazolam in the pediatric population? Yes or no? And the poll number 2 is, when managing a Fontan patient in the diagnostic Cath Lab, which approach do you typically prefer? Number 1 is the sedation with the natural airway. Number 2 is the general anesthesia with spontaneous breathing with some extent of pressure support. Number 3 is the general anesthesia with positive pressure ventilation. Number 4, unsure or no experience. Number 5, none of the above. Well, for the remimazolam, 93% of the audience is not familiar with this drug. So I hope you will know about this more. And for the number 2, the majority will choose a general anesthesia with positive pressure ventilation.
Thank you, Dr. Gina. And now I want to introduce our next speakers, Dr. Tatsuya Hirano and Dr. Norifomi Kuretani. They are from Japan and they will give information about a Fontan patient in the Cath Lab and a very interesting new topic for us, the usage of remimazolam in the Cath Lab. Dr. Tatsuya Hirano is anesthesiologist and working in National Organization Saitama Hospital. His interests are pediatric anesthesia, regional anesthesia, total intravenous anesthesia, and Dr. Hirano Norifomi Kuretani is a chef in anesthesiologist in Saitama Children's Medical Center, Saitama, Japan. And he is also clinical professor in Tohoku University, and he is visiting research associate in Teikyo University. And his interests are pediatric anesthesia, universal coverage of pediatric anesthesia throughout the world. And one of his interests is via biostatistics, generalized linear mixed effects model, missing data, multi-level modeling, and meta-analysis. Now we are listening Dr. Norifomi and Dr. Hirano. It's your turn, please.
Thank you for the introduction. I am Dr. Tatsuya Hirano, a staff anesthetist at National Saitama Hospital and the Saitama Children's Medical Center. Today, I'll be discussing the challenges of managing Fontan physiology in the Cath Lab and introducing remimazolam, a new medication that could be a game changer in our practice. As you may know, Fontan surgery is the final palliative procedure for patients with single ventricle congenital heart disease. This surgery reroutes blood flow to bypass the right ventricle, relying entirely on passive flow from the systemic veins to the pulmonary arteries without the assistance of a ventricular pump. This unique circulation creates several management challenges, particularly in the Cath Lab, where maintaining delicate hemodynamic stability is crucial. At our center, remimazolam has proven valuable for balancing sedation and hemodynamic stability, offering quick onset and controllability. Now, I'll walk you through the perioperative management of a Fontan patient and the strategies we used to overcome these challenges. This is a picture of Saitama Children's Medical Center, located in the suburban area of metropolitan Tokyo. We are the only freestanding children's hospital in Saitama Prefecture. I have no disclosures related to this presentation. Additionally, this presentation has been augmented with various AI technologies, including the latest version of ChatGPT, to enhance its content. Here's today's agenda. We'll start by reviewing a case of a Fontan patient to highlight the specific challenges faced in the Cath Lab. Next, we'll dive into Fontan physiology, focusing on its impact on hemodynamics and anesthesia. Finally, I'll discuss the strategic use of remimazolam, a short-acting sedative, effective in balancing sedation and hemodynamic stability. These sections will guide us through both the theoretical and practical aspects of managing Fontan patients in the Cath Lab. Let's begin with a case selected from our records at the Saitama Children's Medical Center Cath Lab. As a pediatric cardiac center in Saitama, our Cath Lab team regularly handles a variety of complex and interventional cases. This example will offer a clear, real-world context for understanding the intricacies of perioperative management in Fontan patients. We have a 10-year-old boy with a history of tricuspid atresia. He had Fontan palliation when he was 4 years old. He presents with ongoing symptoms of exercise intolerance and cyanosis, which have raised concerns about the function of his Fontan circulation. Given these symptoms, he was scheduled for a diagnostic catheterization to assess his hemodynamics and determine if any interventions are needed. Now, Let's turn our attention to the perioperative management of this Fontan patient in the Cath Lab. Managing anesthesia for these patients is particularly challenging due to their reliance on passive venous return and the absence of a right-sided pump. This raises important questions about how best to maintain hemodynamic stability during the procedure. As we discuss this further, I want you to consider the risks and benefits of each approach and how we can mitigate those risks in a patient with such delicate physiology. Now let's focus on the anesthetic implications of Fontan physiology. This angiogram shows a Fontan with fenestration, meaning the IVC is connected directly to the pulmonary arteries, and you can see blood flowing through the fenestration into the left atrium. Let's take a closer look at Fontan circulation and its anesthetic implications. The Fontan circulation is the final palliative procedure for most patients with single ventricle congenital heart disease. These patients only have one functional ventricle, meaning they cannot use a ventricle to pump blood to the lungs for pulmonary circulation. Instead, the superior and inferior vena cava are directly connected to the pulmonary artery, meaning blood flows passively from the systemic veins to the pulmonary arteries. As a result, pulmonary blood flow is entirely dependent on the pressure gradient between central venous pressure, CVP, and left atrial pressure, LAP. Maintaining an optimal CVP, typically around 10-15 mm/Hg, is crucial to ensure sufficient pulmonary blood flow. This passive circulation is highly sensitive to changes in preload, pulmonary vascular resistance, PVR, and ventilation, making anesthesia in these patients particularly complex. As we move forward, it's essential to understand how these hemodynamic principles guide our anesthetic management, ensuring we maintain the necessary pressure gradients and avoid increases in pulmonary resistance. Now, let's look at the factors that Fontan circulation cannot tolerate, which are critical when managing these patients in the Cath Lab. First, hypovolemia is a major issue because it leads to low CVP, reducing the pressure gradient between CVP and LAP, which decreases pulmonary blood flow. Fontan patients are highly dependent on maintaining adequate preload, so even small decreases in volume can be detrimental. Next, any pulmonary artery or pulmonary vein obstruction or stenosis significantly impairs passive blood flow through the lungs, leading to reduced cardiac output. Increased pulmonary vascular resistance, PVR, is another major concern, triggered by conditions like hypoxia, acidosis, or hypercapnia. Managing these factors is key to preventing increased PVR, which can severely affect blood flow in Fontan patients. Finally, increased LAP due to left ventricular dysfunction, mitral regurgitation, or atrial fibrillation, AF, further compromises the pressure gradient needed to drive blood through the lungs. Now let's discuss some of the key reasons for Fontan failure. Fontan patients can experience failure for a variety of reasons. Obstruction in the Fontan pathway is a common cause, as it impairs passive blood flow. Similarly, the development of collateral vessels can divert blood away from the lungs, reducing oxygenation. Another issue is pulmonary arteriovenous fistulas, PAVF, which allow deoxygenated blood to bypass the lungs entirely. As we discussed, ventricular dysfunction, valvular malfunction, or arrhythmia significantly threaten Fontan physiology. And of course, there are many other factors that can contribute to Fontan failure, making it essential to carefully monitor and manage each patient based on their unique presentation. Now, let's focus on the anesthetic goals for managing Fontan patients in the Cath Lab. The primary goal is to optimize circulation. We need to maintain adequate CVP to ensure proper blood flow through the pulmonary arteries. It's also essential to avoid increases in pulmonary vascular resistance, as this would significantly reduce pulmonary blood flow. This requires careful control of factors like hypoxia, hypercarbia, and ventilation pressures. Additionally, we must maintain left ventricular function and keep the patient in sinus rhythm, as atrial arrhythmias can severely compromise ventricular filling and overall cardiac output. The second key aspect of managing Fontan patients in the Cath Lab is to support respiration effectively. First, it's crucial to avoid high airway pressures. In Fontan physiology, pulmonary blood flow is passive, and elevated airway pressures can significantly impair it. Next, we must prevent hypoxia. Low oxygen levels increase pulmonary vascular resistance, PVR, leading to hemodynamic instability. Finally, maintaining normocapnia. normal carbon dioxide levels is essential. Hypercapnia can also raise PVR, so careful management of ventilation and CO2 levels is necessary to maintain stable hemodynamics in Fontan patients. The final goal for managing Fontan patients in the Cath Lab is to ensure adequate sedation or anesthesia. We need to provide enough sedation to maintain patient comfort and cooperation during the procedure, without compromising the delicate balance of circulation and respiration that is crucial in Fontan patients. It's important to select sedative agents that allow for precise control, enabling us to achieve the right depth of sedation while maintaining stable hemodynamics and ventilation. As we discussed, this balance is especially critical in Fontan patients, as even small shifts in circulation or respiration can have significant consequences. Let's discuss the perioperative management of a Fontan patient in the Cath Lab. Before proceeding with any anesthesia, a thorough preoperative evaluation is critical to assess the patient's current status and potential risks. We begin by reviewing the patient's history, including past surgeries, previous anesthesia experiences, and any long-term medications that could affect perioperative management. We also assess the patient's baseline health and current condition, focusing on complications related to Fontan physiology, such as arrhythmias, heart failure, or previous interventions. Next, we review relevant imaging and lab results, including echocardiograms, cardiac catheterization data, and blood work. These provide crucial insights into the patient's hemodynamics, pulmonary vascular resistance, PVR, and overall cardiac function. By carefully evaluating these factors, we can tailor the anesthetic plan to minimize risk and ensure the best outcomes during the procedure. Proper patient preparation is crucial when managing Fontan patients in the Cath Lab. First, ensuring the patient follows NPO guidelines and maintaining hydration is essential, as Fontan patients rely on preload to support cardiac output. Prolonged fasting can lead to hypovolemia, affecting hemodynamics, so early IV fluids may be necessary. Second, managing anxiety is key. These patients often have significant anxiety, which can increase heart rate, blood pressure, and oxygen consumption. Providing anxiolysis through mild sedatives or behavioral techniques helps reduce stress while maintaining stability. Finally, regardless of whether the Cath Lab is outside the OR, patient safety must be the top priority, following OR safety standards and ensuring all necessary preparations are made. One of the key decisions in managing Fontan patients in the Cath Lab is choosing between sedation and general anesthesia, GA. For the purpose of this discussion, sedation refers to maintaining a natural airway and spontaneous breathing. On the other hand, general anesthesia involves the use of an airway device, such as an endotracheal tube or supraglottic airway. Breathing may be either positive pressure ventilation, PPV, or spontaneous breathing under GA. When choosing between sedation and general anesthesia, GA, for Fontan patients, we must carefully weigh the advantages and disadvantages of each approach. With sedation, the major advantage is maintaining spontaneous breathing, which is more physiologic for Fontan patients. It also allows cardiologists to measure a variety of hemodynamic variables under more natural conditions. However, sedation carries risks such as airway obstruction, hypoxia, or hypercapnia, especially if the patient cannot adequately protect their airway. In contrast, with J, we can maintain spontaneous breathing using techniques like pressure support ventilation, PSV, or use positive pressure ventilation, PPV, for more stable respiratory control. However, PPV can be non-physiologic for Fontan circulation, and it's important to understand that measurements taken during catheterization under PPV may not reflect the patient's natural physiological state. Ultimately, the choice between sedation and GA depends on the patient's condition, the complexity of the procedure, and balancing the benefits of spontaneous breathing with the need for secure airway management and stable ventilation. When selecting anesthetics for Fontan patients, we need to carefully balance the pros and cons of each option. Starting with volatile anesthetics, they offer the ease of titration, but come with the risk of hypotension. Next, opioids provide stable hemodynamics, making them a good choice, but they carry the risk of respiratory depression. Propofol is a popular option because of its ease of titration, but we must be cautious of hemodynamic changes, such as hypotension. Dexmedetomidine offers effective amnesia without respiratory depression, but it can lead to hemodynamic changes. Finally, ketamine is advantageous in that it preserves hemodynamics, but it can increase secretions, complicating airway management. The choice of anesthetic must be tailored to the individual patient's needs and the specific demands of the procedure. Let's now talk about remimazolam, which has the potential to be a game changer in pediatric anesthesia. Chemically, remimazolam is closely related to midazolam, binding to the GABA receptor to induce sedation. The key difference is its ester bond, allowing it to be rapidly metabolized by esterases, leading to a safe and predictable recovery. Often referred to as a soft drug, remimazolam provides quick recovery and minimal side effects, similar to remifentanil. Now, let's focus on some of the unique advantages of remimazolam. Rapid onset. It acts quickly, with a short duration of action. Metabolism. Metabolized by tissue, esterases, meaning accumulation is unlikely, even with prolonged infusions. Flumazenil. As a benzodiazepine, its effects can be efficiently reversed with flumazenil, providing an extra layer of safety, especially in out-of-war sedation. No rebound. Due to its excellent pharmacokinetics, rebound sedation is unlikely after flumazenil reversal. Injection. Unlike propofol, remimazolam causes minimal pain upon injection, enhancing patient satisfaction, particularly in children. Cardiorespiratory stability. Like other benzodiazepines, remimazolam provides stable hemodynamics and preserves respiratory function. Remimazolam has several advantages, especially for our pediatric patients. This paper from our institution summarizes our experience using remimazolam for pediatric general anesthesia over the past 4 years. We've used remimazolam in over 400 general anesthesia cases, covering a wide range of age groups and surgical procedures. For dosing, we typically extrapolate adult dosing regimens to the pediatric population based on body weight. If the child has IV access, we use a bolus of remimazolam for induction. If not, we begin with sevoflurane gas induction. Maintenance is typically at 1 mg in ICHAR, often supplemented with remifentanil. Overall, remimazolam has provided satisfactory anesthesia, with rapid recovery and a comparable rate of adverse reactions. Lastly, let's take a closer look at the case management for this Fontan patient in the Cath Lab. In preparation, we encourage fluid intake until 2 hours before the procedure to maintain preload, and started an IV after NPO. No premedications were given, and the patient received support from the child life specialist. For induction, we used remimazolam and propofol for a smooth induction, with a fluid bolus on hand to maintain stable hemodynamics. For the airway, we used an iGel supraglottic airway, allowing us to maintain spontaneous breathing. Respiration was supported using minimal pressure support ventilation with room air. For the maintenance of anesthesia, we continued with remimazolam, sevoflurane, and propofol. During the Cath Lab exam, the cardiologists conducted pressure studies, oxygen saturation measurements across different portions of the cardiovascular system, and performed angiography. A bubble contrast echocardiogram was also done to evaluate for pulmonary arteriovenous fistulas, which were suspected in this case. Postoperatively, the patient was extubated and transferred to the high care unit with hemostasis under control. Dexmedetomidine was used for postoperative sedation to ensure a smooth recovery. As we wrap up, here are the key takeaways from today's discussion. First, a solid understanding of Fontan physiology is essential when managing these patients, especially in the Cath Lab, where subtle changes in preload and pulmonary vascular resistance can significantly impact outcomes. Second, the goals in the Cath Lab are to maintain stable hemodynamics, optimize respiratory function, and ensure patient safety throughout the procedure. It's all about achieving the delicate balance needed for Fontan circulation. Lastly, the use of remimazolam has proven to be an invaluable tool for anesthesia in these patients. Its short-acting nature and favorable hemodynamic profile allow for a smooth, controlled anesthetic experience, reducing the risks of hypotension and prolonged recovery. In closing, we welcome fellows from across Asia to collaborate with us in advancing pediatric anesthesia care. Thank you for your attention.
Thank you For all unique speaks to our speakers, we have not so many time, so I want to directly pass to the Q&A session. We have already too many questions, and most of them have already answered by our speakers. And here, still we have so many questions, and some of them will be discussed in the discussion and part.
I think we have the question from Dr. Tracy. The question for Dr. Gina: why all the patients of your case was received routine diphenhydramine and hydrocortisone as a pre-medication? Dr. Gina.
Yes, good evening.
Yeah.
It's just an adjunct supplementation for sedation. Actually, we arrive with this pre-medication because not all patients are referred to anesthesiologists. So it's like already like sort of routine for all other patients with or without anesthesiologists to give pre-medication of diphenhydramine and hydrocortisone. So that's why it's already, we sort of already do it routinely for all patients. Even if there's no anesthesiologist, so the patient is already a little bit sedated going into the Cath Lab suite. That's how we do it. Kasi not all patients are referred actually to anesthesiologists, only those more complex ones and longer cases. So if there's the one who do the sedation or the Cath Lab nurses, the staff in the Cath Lab for cases.
And there is a question to all the speakers. Are there situations where anesthetists are asked to set radial lines for monitor or CT lines in addition to the femoral access by the cardiologist? Any arterial line or central venous catheter lines asked by the cardiologist?
I think in my institution, I sometimes was asked to put an A line or a catheter as a more access for the patient with the Cath Lab. For some EP study, for example, when they do a lot of agitation with the arrhythmia, with the rhythm of the heart, and they want to monitor at the real time of the hemodynamics. So yes, my answer is yes.
But in my institution, for Fontan patients, we usually put central venous line in the internal jugular vein. The cardiologist found this before starting the procedure. Dr. Lisa, I think you were talking something.
Usually we have to plan if we think we need some other invasive monitoring, that has to be part of the plan before the get-go. But for routine cases, like for device closure cases, we don't really need additional arterial or venous access for monitoring, unless it's a complex case that we think we need to like check pressures, upper extremity, lower extremity for, say for example, for coarctation or something like that. But for routine cases, we don't usually request for additional lines.
Yeah, and beside that, you can measure the pressure during you do the procedures.
I want to ask a question, my question, about monitorization. In your institutions, do you use, we use a normal standard monitorization technique, but is there any other monitorization techniques like near-infrared spectroscopy NIRS or this monitorization and capnography that you usually use in your institutions?
Can you repeat the question?
Sorry. In our institution, for all patients, we generally use capnography in the monitorization, besides the other routine monitorization techniques. And also sometimes, but not usually, we can use NIST monitorization, but we don't have any BIS monitorization technique. What about you? Are you using usually these monitorization techniques or only the standard monitorization technique?
So in our place, we use standard monitors, ASA standard monitors, and BIS only in the EP studies, because when they use isopril, it kind of guides us that, okay, isopril is messing with the anesthetic, so we need to go up on the anesthetic. But other than that, BIS is kind of not very hip.
It's not too expensive, all of these monetizations also, to do these monetizations.
Well, they are in there. The machines are in there. Module is in there. It is just that BIS doesn't add a whole lot to your overall monitoring experience. That is my personal opinion. But we use it in very routinely in the EP studies.
Yeah, we're pretty basic in terms of monitoring also.
I think we don't have much time for, I think we will save time for two more questions. Is this okay?
We can take some more questions. We can take 2 or 3 questions again. There is a question for Dr. Kurtani and Dr. Tatsuya about remimazolam. In the case Dr. Jina presented, will remimazolam be useful drug as well, and why? There is a question about the usage of remimazolam. I think you recently used remimazolam in the Cath Lab laboratory in your institution.
Yeah, thank you for your question. That's a good question. And we use remimazolam routinely for in our Cath Lab, from neonates to the adult, the bigger elderly, bigger patient, and it found quite useful as Tatsuya presented. It has been introduced for our practice for almost 4 years.
Is there any FDA proof for this drug to use?
Did you say any what?
Any FDA permission for patients, for pediatric patients, for remimazolam usage?
You mean the off-label or something?
Off-label, or
yeah,
yes,
it is.
Yes.
Yeah, the remimazolam is off-label for the pediatric use, but we needed to note that most anesthetics we use like an off-label, like a propofol or acutinium, local anesthetics, all off-label for the pediatric population. And I think we can use the off-label medications by our critical judgment and responsibility. And of course, in our institutions, our medication committee approves our use of remimazolam for the our pediatric patients.
Thank you. And there is another question. Again, for all speakers, is there any strategy for the management of arrhythmias? Is there any protocol that you use in your country institutions? And do you have any comments how much contrast they use? About arrhythmia control, I think he or she wants to ask about the relationship between the arrhythmias and the contrast usage.
I think it's quite hard to say because it really depends on the length of the procedure and depend on the complexity of the case.
Well, contrast use will depend on what you need to see. So, but the basic rule for all cardiologists is to use the bare minimum, so the least amount that you can use to get the information that you need. So that's typically how we approach things. But in terms of how much contrast can be given, so usually that's predetermined. So if you have a kid with, say, a bad kidney or something, so you need to know your limits even before you start your case. So I think the thing is that sometimes somebody just has to remind the operators that, hey, you're going way beyond. So that might be something that anesthesia service can take on.
And another question, where do you follow up after the procedure, these patients? You take these patients into intensive care units usually, or there is a place that you follow up these patients after the procedures?
In our case, I think it's different from most of the other
Yes.
participants here, because I saw the poll earlier. They said that they'd intubate and do GA for routine for the cases that we just do sedation on, like PDA. And when we saw the poll earlier, most of them will put the kids in the ICU, I think, if I remember the poll questions correctly. But in our setting, we actually just put them in the recovery room for a few minutes until they're awake. Once they're awake and they can recognize their moms, they get transferred to the lap of their moms, and then the moms take care of them. So because we believe that the parents are the best people to actually take care of these children, it provides less stress if they're with their moms. So we actually just put them with the mother and then put them in the ward, and then they're just nurses and doctors who actually it's just an extended PACU, so to speak. So it's just the wards with the parents there. So the parents will be the ones to take care of their children so that they don't kick, they don't cry, they strain less. So that's actually, we find, a safer thing to do for these patients. But of course, we need to have our nurses there to monitor their vital signs and all that. But we can just put them safely in the wards if it's just a simple procedure and they're not intubated and there are no significant lines that are inserted in their bodies for the procedure or after the procedure. So we tend to remove everything anyway, except for an IV line. So if that's the only thing that's left, we can bring them back to the wards, and as long as it's they're hemodynamically stable and safe.
Yeah,
Actually,
I totally agree. In my practice, we also do that, and my boss is very pioneer in sedation. And the point here is our confidence of the staff to do the sedation with the procedures and the availability of the equipment.
I want a question to Dr. Lisa. Dr. Lisa, as I don't misunderstood, you are giving anesthesia and you are giving sedation to these patients. Before the procedure, do you inform the anesthesiology in case any emergency or in case any help?
Yeah, so if we think that the patient might need some help, like some problems, we typically call in anesthesia service to help us out. But if it's a standard risk patient, we don't really expect any problems. We usually just go ahead and do the sedations ourselves. So we have our colleagues with us, like other cardiologists and pediatricians, who are actually also well versed in airway management if in case we do need it. But it's not much that we actually need the help of other people in terms of airway management eventually. So, but if it's a high risk patient, of course, we have to go ahead and call everybody in.
Thank you. I think still there are coming questions in the Q&A session part, but we don't have so many time. We have to finish our webinar. And I want to thank to all the unique speakers. You participated from very different regions of the world. And thank you again to all of the participants and all of the speakers. Dr. Shah, please.
You can scan this QR code for the survey and MCQ, and please check that you have correctly entered your full name and email address so that we can send you a certificate of attendance. And we ASPA, we empowering through the education, and we are a non-profit organization. ASPA mission is to foster the highest standard of the pediatric anesthesia care in Asia. We seek your help to donate and help us in our power. So you can scan to donate.
Again, I want to thank to all the participants, all the speakers, and our IT management, Angela. And today we have talked about different anesthetic strategies for the patients undergoing cardiac catheterization. And we see that there is not only one thing that we can say for these patients, but we can say that the most important thing is pediatric patient safety. And our next webinar is about critical life and the role of pediatric anesthesiologists in operating room disasters, which will be held in 17th November of 2024. You can scan for registering to this webinar. And I would like you to join our next ASPA meeting, which will be together with 24th Annual Conference of the Society of Anesthesiologists of Nepal and 21st meeting of the Asian Society of Pediatric Anesthesiologists during 4th and 5th April 2025. Please register and send your abstracts to this meeting. I think we have finished. Thank you again to all participants, to all speakers for their very comprehensive speech, and IT support for Angela.
Thank you.
Thank you.
Thank you.
See you.
We have end now. Bye-bye.
Bye.
Thank you, everyone.
Thank you.